Ron, if you would share, I really have only a couple of companies that are major companies that I love to talk about that took a very CQI approach to benefits, meaning that they purposefully and intentionally asked their employees whether or not the benefits and healthcare services that they were offering were meeting the company's objectives. And Ron's one of the best examples, having led that kind of movement at Procter & Gamble. So I'm going to ask Ron, talk just a little bit about what you did to really drive your health and wellness and benefits to meeting your business objectives.
Well, just as maybe as a quick background, back when I first joined Procter & Gamble, I'd been there a year or so. The CEO at the time was looking to, bend the cost curve, so to speak, on health benefits, and he put together a team to look at, my interpretation perhaps, what we could cut, how we could save money and still offer a decent benefit. I think the wiser physicians at Procter & Gamble saw the new guy and decided to push me to the front because it was somewhat of a risky proposition. But we did a lot of benchmarking. We looked at some really fantastic companies across the U.S. One of them being, for instance, Florida Power and Light, that were really asking the question not only of, how do we provide insurance for sick care, but how do we keep our employees healthy and engaged? And ended up with me with my knees knocking and my voice vibrating, being asked to do a presentation to the leadership of P&G and some of the board about wouldn't it be nice if you gave us $5 million and we'd do a well-being program and we'd solve the cost curve. Well, incredibly, they gave us the juice, and even more incredibly, the cost curve bent. I'm not smart enough to know whether it was serendipity, chicken and egg, but it worked out quite nicely. The title of our program as we launched it was called The Blueprint for Healthy Living. A very science or checklist physician kind of thing that you could expect out of somebody that's been trained in the medical system and grew up in the Air Force. The interesting thing about it is that we approached it from a little different angle, and it was successful enough that the branding people decided to get a hold of it. They changed our logo, changed our title, and ended up calling it Vibrant Living. Along the way, we were blessed by not only providing tools that helped optimize well-being, but they started asking questions about our program in Procter & Gamble's annual survey. P&G at the time had, 80 to 95 million people, 95,000 people, depending on the year, answer a series of structured questions. And pardon the puppy, he's guarding the door. And what became evident over time is that people that engaged in our employee well-being program, our Vibrant Living program, were more likely to be successful, more likely to be happy, more likely to stay with the company. And as the years progressed, we had to defend our cost less and less because we were driving extended benefits. And then, Daryl, if I could, thanks for giving me the microphone. I never let it go once I get it. But
You're fine.
we learned a couple of things about delivering well-being. Many of us grew up in an era, and I'm guilty of, driving programs with asking the question, do you know your numbers? And if we just told people how sick they were too fat, too slow, too ugly. I'm sorry, I didn't mean ugly. Somehow that would change things. And what we learned is that that was just all wrong. And our program, and off the top of my head, let's see if I can remember it. We learned that the most important aspect of a program was assuring that it was leadership led, but that there wasn't just talk. There was leaders walking the walk. And then the next thing we learned is that we really need to be purpose driven. The thing that engaged transformational, sustainable health behavior change really was all about having people understand their why and helping them understand their purpose and linking their purpose and the company's purpose and removing any barriers. And many of the folks, and some people call it motivational interviewing or whatever, many of the folks are able to self-identify the changes they need to make. We then realized that we had to do all this work in an environment where the healthy choice was the easy choice, and then recognize that indeed people do better when they're part of a tribe. And so we fostered self-sustaining social networks where people of like mind on a similar journey, whether it was a diet or an exercise or a mental health well-being, et cetera, they could work with people that they loved and trusted and wanted to be around on the same journey. And then finally, when people were ready, we tried to give them the right information at the right time. That's know your numbers. Daryl, that's probably way more than you wanted, but hey, you asked for it.
No, I appreciate it. Anybody have any questions for Ron?
Well, that was easy.
Thank you.
Before we get into kind of our presentation today, I did want to ask if anybody's discovered anything new, any cool ideas, any new strategies. I wanted to ask the group, I came across a movie called Diagnosing Healthcare. Has anybody watched that movie before? Anybody familiar with the Diagnosing Healthcare movie? One of our advisors, Jeff Ellington, he's not on the call today, was actually in the movie. But maybe during the meeting today, I'll actually put in the chat a link to where you can watch it for free. But it came out about 2020, 2021. Very well done, both in describing the problem as well as, you all know that I've been on this cash pay kick and that we need to move towards cash pay payment. And they actually spent quite a bit of time in the movie talking about the importance of cash pay. So I was delighted to find the movie and thought I'd share it with the group.
Well, Daryl, since you asked, the neatest thing that I found, I hope you all have had a chance to see it. If not, you'll take a look, is the National Academy of Science and Engineering Medicine, their new report, their 2023 report entitled Achieving Whole Health. It's really quite fantastic. And since, once again, I'm jabbering, they have a paragraph that kind of sums up what they wrote in 100 some pages. They say whole health is physical, behavioral, spiritual, and socioeconomic well-being as defined by individuals, families, and communities. Whole health care is an interprofessional, team-based approach anchored in trusted relationships to promote well-being, prevent disease, and restore health. It aligns with a person's life mission, aspiration, and purpose. It shifts the focus from a reactive, disease-oriented medical care system to one that prioritizes disease prevention and health and well-being. It changes the healthcare conversation from what's wrong with you to what's the matter with you.
I love it.
What matters to you, excuse me.
I love it. That is aspirational healthcare in a definition. Go ahead,
Ron?
Steve.
Yeah, thank you. Ron, could you send out or repeat the name of that report, please?
Or you can just put it in the chat. That would be awesome.
Yeah, yes, I will put it in the chat.
Thank you.
And I will do the same with this link. To this movie. It's called Diagnosing Healthcare. There. Okay. Well, we are privileged to be to have with us a representative from Sarah Diagnostics. I think I said that right. Is that right, Sean?
Prognostics. Sarah Prognostics.
Thank you.
No problem.
And I'm going to let Martin do the introductions because Martin's the one who introduced. Martin introduces me to everything, including Nuka. So Martin's kind of my key introduction or introducer. But I really like how they've approached from a very preventative perspective maternity care, and particularly the highest risk and what creates the highest cost of maternity care, and that is preterm births. And so thought you all would be, I think, interested in learning about this. I'm going to let Martin take over and kind of introduce Sean, and then let Sean do a presentation. We can ask her questions and make it a discussion.
Thanks, Daryl. Sean handles self-funded employers for Sarah Prognostics. I was introduced to Sarah Prognostics back in November. I had never learned very much about preterm birth prior to my introduction to Sarah. Was shocked that over 10% of births in the United States are preterm. And I'm sure everybody on this call has got clients that have horror stories to tell about preterm birth and how it impacted their group health plans. Over 60% of the cost of maternity care for a self-funded employer goes to preterm birth. The vast majority of preterm births are actually a financial and a health catastrophe for the families that are affected. The effects tend to be permanent for either the mother or the child or both. Prior to Sarah Prognostics, and what they have created is called the preterm test. Prior to their development of this test, trying to detect those that are at risk for preterm birth was incredibly primitive. There's only really two ways to do it prior to the preterm birth. A history of preterm birth, and of course, if this is a first-time pregnancy, that's out the window. And the cervix can be measured during the pregnancy, and those are the only two methods of determining preterm birth before the Sarah Prognostics preterm test. Over 80% of women that give preterm birth were not considered at risk prior to. So this is an incredible breakthrough. With this test and the proper care, preterm birth can be reduced for less than 35 weeks to 15%, which is a huge improvement. So this is a very exciting development in healthcare, and I am delighted to introduce Sean to you, and I think you're going to be very, very interested in what she has to say. It will impact your clients, I promise you that.
Great. Thank you so much, Martin.
You're welcome.
You're getting so good now at doing the presentation. I think you can almost lead this discussion, which is great. I love it.
Don't say that.
Yeah, Martin, you've been fantastic. Hi, everyone. So nice to meet you. Some of your names are very familiar to me. You've probably seen some posts of mine on LinkedIn, and I've seen some of these names out and about on LinkedIn as well. So nice to be part of this conversation. One thing I noticed, we have some doctors on the call. So I am not clinical. I am from the business side. I am the director of our employer markets. I run our employer markets for Sarah Prognostics, and I have been in the healthcare industry for over 30 years. Yes, I worked for the BUCAs. I know that's probably a bad word on this conversation, but definitely know the ins and outs of the healthcare system and the health plans. But glad to be in a space where we're really making a difference for moms and babies, and I'm super passionate about what we're doing. So with that, I'm going to share a couple of slides. I'm going to try to keep this informal, not so technical, but we will also be happy to take any questions. And I don't know on Zoom, I'm not used to using Zoom. So when I get the slides up, hopefully I can see your faces. If not, if there are questions, feel free to, jump in and ask, and let me switch this real quick. Well, I can. I want to move this over to my other screen view. Bear with me a minute, everyone. Oh, let's see here. Let me go back. Bear with me. I got to figure out how to get this on full screen mode here.
See up at the top of your screen says display settings. You can click on that and basically swap.
I know, that's what I thought. Usually it's there. Where is display settings?
Right up at the very top of your
Top of the
screen. I can see it on mine. So it's up right at the top left-hand side.
You can see it. I can't. That's so weird.
Okay.
It's on the preview page or monitor.
I apologize, everybody. This is why I'm in sales and not technical. But one of these should be able to swap it, I would think, down here. No.
You can close your sharing screen option and then just choose the other monitor when you go to share your screen. So click stop sharing.
Okay, sorry, guys. I hate to do this.
And then when you go to share, this time choose the other monitor.
Oh, I must, okay, because I'm sorry, I thought I picked the right one. All right, bear with me. All right, we're gonna try this one. Sure. I brought it up the same way. Why is it doing that?
We can just go ahead and watch it through the preview.
Okay, I'm so sorry, everybody. Bear with me with that. But can everyone see it okay?
Yeah.
Even though it's not on full screen mode? Okay, I appreciate it. All right. So just a little background on Sarah Prognostics. Actually, we're based in Salt Lake City, Utah. We are the company that's known as the Pregnancy Company. We're a proteomic bioinformatic company focusing on creating valuable pregnancy information and all about improving the well-being of mothers and babies. Our long-term goal is really to come up with other tests which are in our pipeline around pregnancy. Preterm was our first commercial product in the market. And we are looking at creating tools and apps and services that really benefit the whole ecosystem. So it would be patients, doctors, insurers, researchers, and other pregnancy stakeholders. And we've got a very strong scientific group, strong clinical and scientific data within our organization. We're building out expansive data and insights into pregnancy, which is really important. A couple of things, I know Martin touched on this, but I think it's important to just add a bit to this. So in the United States, nothing's been done around the preterm birth rate in over 30 years. We have a 1 in 10 preterm birth rate in the United States. We are actually at par with sub-Saharan Africa, which doesn't say a lot when you look at the healthcare system that we have in the United States today. We should be a lot better off. If you look at the March of Dimes report, last year, we actually had a tick downward, not improvement, but downward with preterm birth risks. In fact, the United States went from a C- to a D+ in preterm births, which is not something that we want to see. And, you know, these are the leading health complications and impacts with mortality. Over 22,000 babies die within the first 2 years due to preterm birth. From a morbidity standpoint, it's the #1 cause of more time in the hospital, NICU, pediatric visits around vision, hearing loss, and chronic lung disease. And then the long-term health implications, right? You've got learning disabilities, early mortality, and cerebral palsy. With our early adopter employers, all of them have had impacts anywhere from minimum of $1 million up to, we've had one that had a $6 million claim due to a preterm birth. And just to define preterm, you may all know it's any birth under 37 weeks. And so when you get below that 35, 34 week mark is where you really are going to see those longer term impacts and morbidity issues, which will actually and could actually stay on that employer's liability as long as they have that dependent insured on their benefits. We're also looking at ways to take a look at creating more health equity. As you can see from this slide, the racial and ethnic disparities in preterm births are pretty significant. The African American, American Indian, Native Hawaiian or Pacific Islander and Hispanics all have the highest preterm birth rates. We're now in a global workforce. We've got people from every background working at our employers. We need to really do something to bring these rates down, not just for those that are severely impacted, but for all. So we're looking at ways to help these companies address this from a DEI perspective and bring more health equity to their populations. Martin also touched on this, which is great. Today, there's only through traditional screening mechanisms, there's only 17% of preterm births that can be identifiable as a potential for delivering early. That's 11% if they're a first-time mom. So that obviously, if you haven't had a birth before and you're a first-time mom, that excludes 11%, right, of the population that can be traditionally screened today. The other 6% is cervical length screening if it's a short cervix. In the case of the 17% here, They are watched more closely, and there are protocol that they do, their OBs or MFM will take them through. But over 80% of the traditional pregnancies, and we're talking singleton pregnancies, are missed. They're absolutely, you know, like they're vanished, they're missed, they're invisible to the healthcare system. And by the time a woman goes into labor, it's too late for them to be able to do much about delivering prematurely. I love this visual, although we're all going to agree, and I like to say this up front, that these numbers are very low. This is just from one case study out of California. Like I mentioned, some of our employers have had anywhere from 1 million plus in preterm birth claims. Over to the left, obviously, is the dollar amount. Down below is the gestational age of birth. What this shows, which makes sense, that the earlier that baby is born, the more cost is in the system, because these babies are not being born healthy. They're spending more time in the NICU. If we can move the needle by a couple of weeks on gestational age, you can see how significantly those costs come down. And that is because these babies are being born healthier. And obviously we want to get them as close to that 37-week mark as possible and over the hump to full term. But you can see by just shifting a couple of weeks what a difference it makes in the baby's health, as well as the economics for an employer. So I'm going to talk a bit about our test now. It's actually the first and only broadly clinically validated test in the market today for preterm birth. We're providing an early individualized assessment of spontaneous preterm birth. And this, again, as I mentioned, is for singleton asymptomatic pregnancies, because there's already protocols in place for people who are having multiple births. So with our preterm test, we analyzed 2 proteins that contribute to preterm birth, and I'm going to get into those in just a moment. And based on how they're performing, we'll put them at a risk scale, and we'll share that with you. This is a single blood draw. It's a one-time blood draw. It's done between weeks 18 and 20.6 weeks of gestation. And the reason for that is we found, which I'll show you in just a moment, is that is the best time that these 2 biomarkers perform at their highest to be able to tell them their risk for preterm birth. Seroprognostics, we have our own CAP-CLIA lab in Salt Lake City, Utah. So when the lab draw is taken, and the blood is then sent to our lab for all the resulting, and we have around a 7 to 10 day turnaround time from receipt of the blood. So this is where I want to spend a little bit of time to help you understand, you know, what are those biomarkers and what are we really looking at to determine someone's risk for preterm birth. Over on the left-hand side, you can see here, this is what we call IBP4 for short, but it's the insulin-like growth factor binding protein. It's really has to do with the growth of the fetus and the nutrient to the fetus, so how that placenta is latching on and how that baby is growing in the womb. If you look down below here, you can see the purple line is normal term deliveries. And the orange line here is the spontaneous preterm birth for IBP4. So you can see that between that 18 and 20.6 weeks, the IBP4 is really upregulated in the blood versus normal birth. Over to the right is SHBG, that is the sex hormone binding globulin. And that's really around stress and inflammation, which obviously makes sense. I think we all know, working in this industry, stress and inflammation is the #1 cause of a lot of disease states and a lot of negative outcomes. So with this, again, you can see here, the purple again is normal term delivery. And between that 18 and 20.6 week marker here, SHBG is downregulated. So when you look at that upregulation of IBP4 and the downregulation of SHPG, there's an algorithm based on this that will put them at a risk scale, which I'm going to share with you in just a second. So once that blood is drawn and comes back to us and we're resulting, this is what's going to get back to the provider to let them know if a patient's at high risk or low risk. If you see hopefully you can see my mouse here on the screen, this really fine gray line here. That's the average population risk for spontaneous preterm birth. What we found through all of our studies is anybody at 2 times the average population risk, which is around 15% or higher, is really at high risk for spontaneous preterm birth. And that's due to those 2 biomarkers we just discussed. So they will be put on a risk scale, and you can see this patient's at 23% risk of having a spontaneous preterm birth, which is 3.2 times the average population risk, and it's putting them at higher risk. The nice thing about our test is our negative predicted value. So if you come back at low risk is at 99%. So if you come back at low risk, they're pretty much taking a lot of anxiety and stress off of the mom, knowing that they're not going to deliver prematurely. Now, if somebody comes back at higher risk, there are evidence-based interventions that work, which I'm going to share with you as well. And one other thing I'd like to point out here is based on all of our clinical studies, the higher a mother tests on this risk scale directly correlates to how early that baby is going to be born. So if you're out here at 7 or 8 times the average population risk, you're looking at 28 weeks, very, very early babies that are going to need a lot of attention and care. So we kind of discussed this already. 17%, are able to be identified through traditional screening methods. But with our preterm test, we're able to provide guidance for the 88% that typically can be missed. And you can see at the bottom, the sensitivity for our test is 88%, 75% specificity. And for pre-screening lab, a preventive lab, these are actually really good sensitivity and specificity numbers. And then, of course, our negative predictive value at 99%. So everyone asks, great, once somebody's identified as a candidate potentially for having a preterm birth, what can they do about it? And there's a couple of things that have proven to be very successful. But first area of treatment, which would be the baseline for any treatment for a mother at high risk, is care management, in other words, case management. And I'm going to take you through what our studies have proven to show with outcomes with our test and treat strategy with case management alone. You can tell obviously that each day matters, that baby's in the womb. The longer that baby is with the mother in the womb is going to help them deliver a healthier child with more of their organs developed, especially the lungs. Respiratory issues for very early preemies tend to be a big issue. And with this, you can see the control arm here is in the orange. The purple is the screen arm, those that were tested and treated with care management. Every little nick on the curve here is a birth. There was one outlier in the test and treat strategy that was around, a little over 30 weeks, which was still, a pretty good outcome. Obviously, we want to get them as close to 37 weeks as possible. But based on our test and care management alone, we were able to reduce babies born before that 35-week marker by 88%, and that is significant. This is a huge, huge victory. The next is going to be improving outcomes in the NICU with respiratory support. Again, you can see the control arms in orange. The test and screen treat arm with care management is in the purple. We had an 80% reduction in days spent on respiratory support in the NICU. It's kind of hidden by the big circle here, but if you look at the baby here, hooked up to machines, on ventilators, obviously this impacts not just the mom and dad, but the entire family, grandmothers, aunts, uncles, everybody is worried about this child and what their outcome is going to be. So this also, if you look at the employer perspective, there's more than just the health implications and costs. There's indirect cost where employees have to be, either resign because their child is born very sick and they need to stay home now and take care of them. There's leave of absences where they need to be with their child in the hospital. And there's presenteeism where people are showing up for work, but they're not really there. And ultimately, this really has a mental, a physical, and emotional ramification for those in the workplace, which distracts them from giving 100% in the workplace. So that really has some significant outcomes as well. But we're really happy if we can not keep those babies on respiratory support, is showing that these babies are being born with stronger lungs, which is obviously really good for their outcome. And then when you look at severe morbidity and mortality, I know this was talked about a little bit earlier in the group discussion today. We have a 71% reduction in babies born with severe morbidity and or mortality. You all are probably very familiar with the neonatal morbidity and mortality rate. It's a score of 1 to 4. Obviously, 1 is, the baby's is pretty healthy. 4 is actually infant mortality. So when you look at the numbers here, you might say, boy, those are low. But again, you're looking at a 1 to 4 scale here. A 71% in babies that are born and sicker and having issues is really reduced, which is also very important to note. And then all of the employers that I've talked to and have implemented our test, they see the claims that usually blow them away and are catastrophic from just the NICU length of stay. I also have to help them understand that it's not just the NICU length of stay claims, but it's if these babies that are born early have significant health complications or long-term health implications, they're going to have that continued cost as that baby is insured with them. So we've been able to prove through our test as well that we had a 60% reduction in NICU length of stay just by using care management alone. And that's significant with cost and health outcomes. So each day matters. Increasing gestational age at birth obviously brings healthier outcomes. The reduction is due to these babies being born much healthier. So this is just kind of recapping the 88% reduction in babies born before 35 weeks and the statistics that we just talked about, the reduction in days spent on respiratory support, the morbidity and mortality, and the length of stay in the NICU, all very significant when you look at these babies. A lot of people have asked us too, so what goes into care management or case management? And we actually have put together what's working with our case studies and what we've used. Basically, it's weekly calls or an app-based platform that needs to transpire with the mother-to-be who tested at higher risk. There's more of a focused patient education around the mother. We want to make sure that they really understand preterm birth and what going into labor feels like early. Some people just may have pain in their lower back and they might just ignore it and think that's just part of being pregnant. Or they ask their family members, people think there's, Braxton Hicks contractions and they don't do anything. They use Dr. Google and try to figure out what's going on. That's not what we want. We want them to understand what potentially could lead to a preterm birth. So if they have any signs or symptoms, they need to go to the hospital because there's still a chance that that baby can be kept in the womb through other means of steroids and cerclage and other mechanisms. So that's really important. Obviously, directed lifestyle modifications. We want people to eat healthy, obviously not smoke, smoking cessation discussions that need to take place here. So there's some of those that obviously are key factors into preterm birth. And then again, they may need more visits, a visit or two additional with the OB and or MFM, depending upon, again, looking at that risk scale and how high, and of course, their physician's guidance. So this is another way for the physicians too, to be able to give resources and time and attention to those most at need. If they're able to screen their patients who are pregnant and determine those at high risk, they can give more of their resources, time, and attention to those patients than those that come out at lower risk. Right now, they're trying to give them to everybody because they don't know for over that 80% that is invisible to the healthcare system. So this is really helping them to hone in on those at higher risk and be able to give them the support, time, and resources that they do need. So just to sum up, preterm obviously enables more accurate identification to be able to understand who's really at risk for preterm birth. And there are ways that they can have treatment to be able to keep that baby in the womb much longer. So we know it's a leading cause of morbidity and mortality. This gives them a very early risk assessment to understand their risk. It enables, improved neonatal outcomes by having informed, actionable decisions. And, our test is innovative. Again, we are the only test in the market today to be able to identify the risk of somebody having a risk, for spontaneous preterm birth. And before I wrap up, I also wanted to share with you, we gave you the results here on case management alone. There are studies that we have done with a bundled approach. We obviously educate our physicians who, we've got a whole team of people out in the field working with the OBs and MFMs, obviously writing our test and giving them the outcomes of our test. A bundled approach could entail care management and progesterone, or care management, progesterone, and low dose aspirin. So the clinician is really going to be the one that determines the right protocol that they want their patient on, but care management will be a key element to all of the patients that get tested at high risk. There's been recent controversy, I want to bring that up because I'm sure it might be a question, about McKenna's 17 OHP, which is the injectable progesterone. There is an article that was published by SMFM, Society for Maternal and Fetal Medicine, that actually summed up in their assessment that they do think the injectable progesterone is worth using, but some clinicians might not find it a part of their protocol. We are finding vaginal progesterone to be another way that they use, so it's not always the injectable. They can use the vaginal progesterone. It does tend to be a little bit messy, and sometimes the patients don't like to use it because of it being a little messy, which is why it's important to have care management, making sure that when they do their weekly outreach, they're having the patients comply with treatment. Obviously, they need to be in the right course of treatment and stay on treatment to have better outcomes. So with that, I'm just going to stop sharing and open it up to questions that I might be able to answer for you.
I've got some questions for Sean, but I'm going to just open it up and see if others have questions, or if Martin, you got a comment or add anything.
Well, the fact that this can be a turnkey approach is very attractive. I've called on self-funded employers for quite a while, and when you bring them Snap-on service to them that involves dealing with the specialists and their networks, sometimes that doesn't coordinate very well. And the fact that Sarah can come along and provide a turnkey service here is very attractive from a broker standpoint for sure, but it's a much more attractive service for a self-funded employer because you can make sure that your employees get the care that they need when they need it.
And one thing I forgot to mention, preterm birth or high-risk maternity is in the top 5 cost for employers. I have been now working with Sarah Prognostics going on about 2 years. I've been in front of the broker community consulting homes as well as the employers. We actually have fully insured and self-insured clients. Most people are shocked that we have fully insured because they see the need for this test. And we are not in medical policy yet with the health plans. That is something that will take time, as with any new service that comes to market. It took NIPT about 12 to 14 years before they got a medical policy with the health plans. We do not think it'll take us that long. We already are doing some other additional clinical studies with a major carrier, which will be reported out most likely next year. So there's a definite need here, and every employer that I sit down with and talk to have all experienced preterm births from the health and economic perspective. And I'm not saying this because I'm not trying to sell anybody, but it's really refreshing to hear employers say, this is a no-brainer. And I love when they say that because it is a no-brainer. There's something now that we can do to help that crisis, preterm birth crisis.
Cool. I've got a question, and that when you and I spoke the other day, I asked you questions about, how are you helping the OBGYNs and MFMs that are specifically working with the employees of the groups you work with. And I was very delighted to hear the length to which you go at identifying for an employer the OBGYNs and MFMs that work for that population, and then proactively reach out to them so that you can get in front of things. So share with the group a little bit about what you do when you bring on an employer.
Yes, thank you very much. Implementation, by the way, is extremely easy for an employer. There's no file feeds needed that take, as we all know, long periods of time. It's really a communication campaign and how we get member engagement. Then, of course, the claims aspect, which is very, very easy. But from the standpoint of implementation, we always ask upfront for the list of the top utilized OBs and MFMs. We've got a whole field of regional account managers that are out in the market today, talking with the doctors, the hospitals, the medical systems. And so we do an outbound campaign. Obviously, the employer gives us consent to do so. So we originally start with an email blast that lets them know that XYZ employer is now contracted for the preterm test. You've been identified as having patients in your population that utilize, you as a physician as an OBGYN. So they're getting that notification up front. And then we follow back up with our feet on the street, our RAMs, that go in then and have those further discussions with them about the test and treat. We don't want doctors to be caught off guard with the employee come in asking for a test that maybe they just don't know about. Vice versa, we want them to be obviously writing the rec for the employee population proactively. So any way that we can educate the employee and the physician, we're doing everything we can to make sure that that engagement takes place.
Nice.
Yeah.
Other questions? Dr. Testa, you said that you have a neighbor who just had a 3-month early preterm. Anything you want to comment on that?
Yeah, I mean, he was super excited, obviously, but, I'm thinking in the back of my mind, the cost of all this, because they don't think that baby's going to come home. Now, he was healthy, but he was 1.5 pounds, and they don't think that baby's going to come home for 3 months.
Yes.
And, she was seemingly healthy and, no big red flags other than she was advanced maternal age, I believe 40 years old. And nobody looked into anything like that. Now, thankfully, Presbyterian St. Luke Hospital here in Colorado in Denver does a really good job. That's one of their major niches and specialties. So she ended up at the right place. But yeah, in my mind, understanding these costs, I was like, wow, how could, and you just answered that question today, Sean, how could people predict this?
Right. And, it's a crisis. I hate to say it, but again, top 5 cost for these employers. And to hear some of these stories, we were at a conference recently where the Miami-Dade Public School District just had a $2.5 million preemie. There was one employer, had 100 employees. They decided 1 year, the first year, to not be fully insured and try going self-insured. And they had a preterm birth that almost made them shut their doors. So it was very significant. Now, as you mentioned, people are typically healthy. There's no known factors outside of that 17% until our test that will tell somebody who's traditionally healthy if they're going to have spontaneous preterm birth until they go into labor. It sounds like that's what happened to your neighbor. But now there is, and now there's something they can do about it.
Yeah, and your other point too, we had a friend who delivered early with a genetic, I forget what it exactly was, but she was a C-suite director of biz dev at a local hospital, and that baby was in the hospital for 6 months. The hospital that she worked for had to, they let her go. Thankfully it was I believe it was an Adventist hospital, and they gave her a year's severance, understanding how difficult this was, but she never went back to that work again. And, it was obviously that baby, only lived a few more months and then died. But, the repercussion on the family, the cost, her career, you're telling totally real stories. It made me think of her.
Yeah, and we've got videos on our website. I welcome you to visit from a doctor that talks about preterm birth. She's actually located in Northern California and prescribes our test to a lot of the tech industry employees. She's wonderful, and she's got stories that you wouldn't believe, actually real life stories, and how our test actually really helped, especially one of her patients who almost went into the hospital with a preterm birth. So really, really great. And I'd really love for you guys to go out and listen to them.
Sean, can you share with us the cost of the actual test? Because if a plan doesn't cover it, somebody may say, hey, it's worth it to me to just pay for the test so that I know that my wife's not going to have preterm birth. Or if it is, they're going to be something I can do about it.
Yeah, so I'm going to come from the employer perspective first. That's sort of my market, and then I'll talk about individual in just a moment. So from the employer perspective, our baseline cost for our test is $975 per test. And CMS did give us a price point about a year and a half ago, and their price point's $750, which, as we all know, they bill 2 times, 3 times their rate. So we are negotiating with our employers anywhere between $750 and that $975 mark, depending on size, obviously, of the group. So we, are obviously trying to make this very affordable for employers. The NIPT testing way back when really impacted physicians in the sense of testing, because they were getting $14,000 bills for NIPT back in the day. We don't want that shock value. We see the need. We're able to give a competitive price. Now, for individuals who go in and don't have coverage through their health plan or an employer, because we are we're commercializing and we're out in the market in these early stages, we're willing to work with them on the price. Yes, the baseline price is still $975. However, we are submitting claims, by the way, to health plans for those individuals. We are getting their ID cards, we're submitting claims, and believe it or not, we are actually having a lot of the health plans pay those claims, even though we're not in medical policy. We've got a great appeals process in place where we are appealing those claims that come back denied, and we are getting payment. We will take what the health plan is paying for the test at this point. If there is no coverage that the health plan won't pay, or they don't have insurance, we also have funding that we can supply for them, like payment options. So we're really being as flexible as we can with the population.
This whole risk of maternity care reminds me of specialty pharmacy. If you look at the entire pharmacy bill, which is huge, close to 20% of the total medical bill, specialty drugs represent now about half of the total cost. So this little tiny sliver of people are representing a half of the cost. It's very similar in maternity. What you're saying is that this tiny, tiny sliver of preterm births represent over 50% of the total cost. And wouldn't it be nice if we had a preventative screening test for specialty drug where we could avoid specialty drugs, but we do in maternity, so why not use it?
Right. So the March of Dimes report will also show you that the annual cost per year to our system is, like, as Martin referenced earlier, 25 billion. That was, 25 billion. But if you look, that was a 2016 stat. If you look at the statistics more recently, we're up to about 35 plus. So it's a continuing need that keeps adding more and more cost into the system, which really can be now hopefully avoidable for spontaneous preterm birth. Medical, obviously, preterm births, that's a whole different animal, and not what our test obviously is testing for. We're talking about those who otherwise would not know and just go into labor.
Is it recommended that every woman have the test if they get pregnant?
If there are singleton pregnancies over the age of 18 and have no known, fetal issues or problems, yes, absolutely.
Good to know. Other
And
questions?
the test works equally well across all demographic groups.
Absolutely. Does not discriminate.
Anybody else have any questions for Sean?
Great. Well, thank you so much. Feel free to
you.
reach out to me if you have other questions or would like more information. I'm happy to continue to help assist you all.
And her email is a part of the email chain that went out for this meeting. So feel free to connect with her through email. Our next meeting is going to be in a couple weeks on March 24th. And Dr. Testa is going to present this whole Regenix and stem cell and regeneration, regenerative medicine arena and what they're doing in that area. So Mark, thanks for being willing to present at our next meeting. And with that, we'll wish everybody a great weekend.
Thanks,
Great. Thank you.
Thanks, Daryl. Thanks, Martin, everyone. Have a nice weekend.
Daryl.
Thank you.
Take care.
Amazing. Thank you.